I'm going to start off speaking about really kind of the St. Joe's experience with this outbreak, and then Chris is going to follow me and talk about the Traverse City experience. I have no disclosures. So I'm going to just spend a little bit of time talking about the background behind this outbreak. Many of you know, this is well known, that the first case was described at Vanderbilt on September 18th, and it was actually the only case of Aspergillus infection related to this outbreak. And many of us actually wonder even if it was a case related to this outbreak, but I think no one will doubt that it spurred all the CDC and public health authorities to move forward. About 10 days later, the initial investigation by Tennessee Department of Health and the CDC and the North Carolina Department of Health identified 8 patients with culture-negative meningitis. And the common link between all these patients is that they had received epidural steroid injections with methylprednisolone acetate. So many of you know this. MPA was compounded by NEC, the New England Compounding Center. There were 3 lots indicated in this outbreak, and the lots are actually named for the time that they were manufactured. So there is the 05 lot, the May lot, the June lot, and the 08 lot, the August lot. The 06 lot has been often called the hot lot, a higher incidence of infection associated with this lot. And on the 25th, NEC was informed of the investigation. In total, there was about 17,500 vials of MPA that was recalled. I think they were actually able to recall about 3,000 vials were actually not used. There's about over 14,000 vials that were injected, and that involved about 11,000 or so patients. On October 1st, that was a Monday, the Tennessee Department of Health, they had kind of press and media briefings. I think the following day, October 2nd, there was a article by Denise Grady in the New York Times, and there was a lot of media coverage. And it was, I think, October 2nd, or yeah, the following, October 2nd was the last day in the country that injections occurred with NEC products related to this outbreak. At the same time, at our own institution, it was a Wednesday. We'd been talking probably for a while before this, maybe a month. The first case that we saw was over Labor Day weekend, but we really hadn't put all this together. It was different rounders. We're seeing different patients. Some patients were getting discharged and coming back and being seen by different providers. But at that time, on that Wednesday, we had identified 6 patients of our own that had culture-negative meningitis. And then on October 4th, this was later on in the day, this is the first Health Alert Network notice that was published. And this really was describing the morbidity and mortality that was associated right before this outbreak was well recognized. So in total in Michigan, there was 4 facilities that got products. Facilities in Grand Blanc, Brighton, Traverse City, and Warren. Facility B, which is the Michigan pain specialist here. This is a private practice pain group. A majority of their patients have presented to our institution. So in total, the 4 facilities in Michigan received over 2,000 vials of MPA. This included single-dose and multi-dose vials. There's about 1,800 exposed patients in Michigan. And Facility B, the facility in Brighton, injected over 750 injections in about 625 patients. And of these injections, about 652 were spinal and paraspinal injections. This here is a schematic, and I'll actually have another picture about this. You can see that this is this is like a translaminar ESI, epidural steroid injection, in between the spinous processes. And this is another picture, the spinous process, the transverse processes here. And you can see that the more common of the injections is an intralaminar or translaminar injection across the lamina. And there's also a transforaminal injection, which is across the neuroforamen. From my understanding is the translaminar injections often require a larger size needle, smaller gauge, and it's usually one type of injection. The transforaminal injections sometimes require multiple injections. So the first few weeks of this outbreak is mostly fungal meningitis. And the patients presented with headaches, meningeal symptoms such as photophobia, nuchal rigidity, neck pain, subjective fever, often had waxing and waning symptoms. The pleocytosis ranged from less than 10 to 15,000. Initially, the CDC guidance was the surveillance and case definitions was greater than 10 white blood cells. And then actually after a week, the definitions were revised to greater than 5 white blood cells. So there was probably a couple patients in there that we saw that had 5 to 10. And I'll talk a little more about this later, but I wonder if they probably actually didn't have meningitis. The CSF was described usually with a low glucose, elevated protein, but it was not always neutrophil predominant. And the symptoms didn't always correlate to the degree of CSF pleocytosis. The weeks 3 and 4 of this outbreak, many of these patients that had fungal meningitis that had been discharged and were often already at home on oral voriconazole had represented with infection at the site of injection, whether it was an abscess, a phlegmon, or arachnoiditis with intradermal involvement. And at the same time, around late November and early November, or late October, early November, we started seeing a new group of patients, and which has become the predominant manifestation of this outbreak. And it was this patients that did not have meningitis that had infection solely at their injection site. And since that time, even as most recently as this past week, we've continued to see spinal and perispinal infections, including early on those that had meningitis. And primarily in these patients, symptoms were back or neck pain, radiculopathy, lower extremity weakness, pain at their injection site. But there were some case patients that we saw that had very little symptoms. It was actually very alarming and very troubling. And it was this that spurred our health system to screen every patient with an MRI that underwent a spinal or perispinal injection. And when I talk about spinal and perispinal infections or perimeningeal infections, I'm talking about epidural infections, abscesses or phlegmons, perispinal infections, arachnoiditis or clumping of the nerve roots, osteomyelitis, discitis, and soft tissue infection. When we talk about perispinal infections, we're really referring to infections involving the facet joints, the soft tissue muscles here, the ligaments of the perispinal muscles. Epidural abscesses, outside the dural space. Intradural infection within the dura, arachnoiditis, nerve roots, and vertebral osteomyelitis and discitis. So in early November, we started screening folks with an MRI. This is actually a kind of a monumental task when you talk about screening hundreds of patients. We required an emergent mobile MRI scanner. The state provided expedited approval for this. And I want to just share with you some data on a couple hundred patients that had actually never had, there's a couple hundred patients that had never presented for care. They actually did not have a prior LP, they had not visited St. Joe's, they had not come in through the ER, they did not have a previous MRI. And many of the patients that we found to have abnormal MRIs, we actually deemed as asymptomatic because they actually had little change in their baseline symptoms, but they had abnormal MRIs. Many of you know that a lot of these findings and findings in other states from Tennessee, mostly Tennessee, actually spurred later on notices from the CDC about really having a low threshold for imaging. This here is some data that we submitted back in late January for publication. And you can see here that this is, there's over 200 patients that had not presented for care. And of these 218 patients, 155 by the 3rd or 4th week in January were able to get one screening MRI. Of these screening MRIs, 20% were abnormal, so 31 were abnormal. What I mean abnormal is they had evidence of a spinal or paraspinal infection. So either they had an abscess or a phlegmon, either in the epidural or paraspinal space. They had arachnoiditis, vertebral osteomyelitis, or had moderate or severe enhancement. And of these 31, 30 received treatment, 10 were just plain old medical therapy, and 20 went to the operating room. Of these 20, 70%, or 14 of them, had confirmation of pathologic confirmation of fungus, which is actually a pretty high rate of confirmation for this outbreak. And the images that were equivocal here, these were images that they weren't normal, but they weren't abnormal. These patients had ongoing clinical and radiologic follow-up. Most of this group did not progress with abnormal MRIs. That being said, we have had patients that had normal MRIs in October that as late as February had MRIs that became abnormal. What I want to highlight here is of these 31 patients, about 40% of them had little change in symptoms, or really their symptoms were at baseline. This is just another slide just showing the various types of disease that were picked up by MRI in these 30 patients. As you can see here, many of these patients had more than one type of infection. We've also seen peripheral joint infections. We've seen about 12 or 13 peripheral joint infections. I think the most recent peripheral joint infection we saw was last week, and that was a hip. And these have involved shoulders, hips, knees, ankles. These injections actually even occurred in peripheral nerves, such as tarsal tunnel and carpal tunnel areas. And these patients often had pain at the injection site, not always. And sometimes the pain became soon after injection. I think Chris will spend a little more time talking about this specific group of patients. I think it's important to talk about therapy. Week 1 of this outbreak, most patients received 2 drugs, and 2 drugs were voriconazole and liposomal amphotericin. The CDC guidance changed on this also, and remember that first week, many of these patients seemed to be doing well, and the hope was, okay, well, you know, we'll be able to treat patients 3 months, and hopefully we'll be able to be done with this outbreak. And so the pendulum kind of swung, and weeks 2 and 3, we treated many patients with 1 drug. And then around the same time, in the 3rd or 4th week of October, a lot of those patients with meningitis had now returned with infection at their injection site. The concern was, well, were they progressing on medical therapy, or was this, you know, just the disease, the disease just kind of evolving? But the way we treated these patients and our approach to these patients really changed around that time. We treated most patients with combination therapy, liposomal amphotericin and voriconazole, and really the duration varied based on their disease presentation. If they had arachnoiditis and they had severe symptoms, we sometimes treated patients for up to 6 weeks. If they had spinal and paraspinal infections and they underwent surgery, the range of treatment was usually for 1 to 2 weeks. Voriconazole, lots of side effects with voriconazole. I don't think any of us would have envisioned the difficulty patients have had with taking voriconazole. Most of the common effects we knew about, hallucinations, photopsia, QT prolongation, LFT abnormalities, drug interactions. But really the most common effects, I think, have been CNS effects. And really it's this description by patients of trouble thinking, fogginess, just difficulty even getting, following directions, basic directions. And with prolonged therapy, we've actually seen some effects that have not really been well described. Alopecia. In my clinic over the last 2 or 3 weeks, I think all but one of those patients has had alopecia. Periostitis. So this is an effect that's due to fluoride. So voriconazole contains fluoride. Fluoride can stimulate osteoblasts, and this can actually form new bone. And I mean, we need a certain amount of fluoride to keep your bones healthy, but too much fluoride can put patients at risk for osteomyelitis and fractures. And periostitis, from seeing this really in the last month, the patients, this is actually very, very difficult for them to deal with. They complain of pain all over. Pain in their long bones, pain in their arms, pain in their legs, and quite difficult. I think a lot of the side effects that we're seeing are dose related. We're using higher doses of voriconazole than we've ever used before. We're using sometimes to try to, we were fixated on trying to keep these levels between 2 and 5. And because we've tried to keep these levels between 2 and 5, we've sometimes gone upwards on doses up to 10 mg per kg twice a day. I think the troughs are all across the board. Initially, for the most part, they usually started high, and then they often kind of came down. Some remained therapeutic between 2 and 5, but some actually were really on the lower side. Some patients, we actually even tried TID dosing, and even with those patients, we had difficulties trying to get those troughs to this level. We did some creative things to try to get there. We put a fair amount of patients on Prilosec and other proton pump inhibitors. Those medicines are CYP219 inhibitors and help increase the dose of voriconazole. Amphotericin, well, we all know about the drug infusion reactions and the nephrotoxicity. I think the electrolyte abnormalities is probably something that I think that we've seen, but really the potassium wasting and the magnesium, the issues with the magnesium are really real. And the potassium wasting, I mean, we had people on potassium, I mean, all the time. And this was quite difficult. And to try to prevent the nephrotoxicity, we had a lot of people on continuous IV hydration. I mean, we had some patients gaining 60 pounds in just fluids alone. This is a slide taken from the CDC, and this is antifungal susceptibility testing of Exarohyalum rostratum. And really, this is the predominant fungus associated with this outbreak. And so this is data based on 50 isolates that they were able to culture. And what I want to point out here is the MIC 50 and 90 for voriconazole, it's relatively high, 1 and 2. Itraconazole and posaconazole much better, but then there's really this concern of CSF penetration for the patients that had meningitis. Amphotericin, you can see here the MICs are much lower. And in our experience, and I think most providers would share this, that we found that amphotericin, when tolerated, to be a much better drug for this disease. Well, I talked a little bit about toxicities. What about costs? Well, these drugs, to no surprise, are very expensive. Our inpatient budget from October to December, just for antifungals, was $1.5 million. To put that just kind of in a frame, that was more than our total antimicrobial budget at St. Joe's Ann Arbor from years 2011, 2010, et cetera. Our outpatient budget, so we're just talking about voriconazole alone, budget from October through January was almost $1 million. Voriconazole for an 80 kg person at 6 mg per kg dosing, it's about $500 per day. And liposomal amphotericin, this cost actually came down significantly during this outbreak. It was much more expensive at the beginning of this outbreak, was about $400 per day. The monthly outpatient costs, now all these patients were able to get voriconazole, whether it was through the compassionate use program or whether it was through the hospital, helping them through hospital support. Insurance costs were often $3,000 to $7,000 a month. This here is a slide from our marketing and communications department, and you can see here this blue line is reflective of how many cases we've seen. This is, what is that, about 200 there, so this is hovering about 190 there. And this is our inpatient census. At the peak in November, I think in the second week in November, there was a time where we had 79 inpatients, which is, I mean, that's, when I look back, it's just staggering. That was 1/5 of our inpatient census was related to patients with this outbreak. I mean, it was so bad that elective surgeries were getting pushed back. And at one point in time during this period, our best friends were literally the neurosurgeons, who we kind of seemed to see all the time because they were operating on a lot of these patients. During this first part of October, I think the most amount of LPs we did in one day was about 65, but we had a couple hundred people that presented to the ER. This is data that you will hopefully see soon. This is from Tom Chiller in the CDC, and this is about to be submitted. And this really kind of describes what we've seen at our own institution. And this here is about 678 cases associated with this outbreak. So this is through the end of January. You can see here that dark blue is meningitis. In the first part of this outbreak, largely up until late October, early November, was meningitis. The green is spinal and paraspinal infections, and since that time has really been spinal and paraspinal infections mixed in with some joints here and there. And most of the morbidity associated with this outbreak has been associated with strokes. And really the cases of meningitis that went unrecognized early on. This is the CDC map. This is as of a couple days ago. Now they're updating this map every couple weeks. So as of a couple weeks ago, or even yesterday, there were 722 cases reported, probable and confirmed. And in the 4 states that have really been hit the hardest are Michigan, Tennessee, Indiana, and Virginia. So at our own institution, we've seen 190 cases, actually 192 now. And the large amount of these cases are spinal and paraspinal infection. A fair amount of meningitis, and most of these patients have had spinal and paraspinal infection. The patients that actually did not have spinal and paraspinal infection in this group are patients that were unable to undergo MRIs. They either had hardware or they unfortunately died early on, or they actually didn't indeed have meningitis. I think in the patients that we've seen related to this facility from Brighton, if you really truly had meningitis, you actually really did develop a spinal and paraspinal infection. They're actually almost the same type of a patient when you think about the patients with meningitis as opposed to the patients with the injection site infections, other than these patients developed meningitis. We've also seen a fair amount of peripheral joints and in a patient with concomitant infection. Now the confirmation rate in terms of how many actually had confirmed extraohylum is about 30%, about 58, and this is what's reported thus far in the country as well, about a 30% confirmation rate. Extraohylum, we know that this is a dematiaceous or black mold. Melanin is found in the cell wall, it's found in the environment, plant debris, soil and water. And prior to this outbreak, there was less than 35 cases described in the literature. It was very uncommon, very rare, and I think that's what made it made it difficult to know kind of what optimal management was. We didn't understand really the pathophys of this mold. So I want to just go through some cases. In some of these cases, actually, I have 3 cases I'd like to go through. In 2 of these cases, I actually presented at the November meeting, so maybe if some of you were there, this is kind of a follow-up, and I can kind of tell you what's happened to these patients. So the first case is a 72-year-old female who underwent an L3, L4 ESI on September 20th. She presented about a couple weeks later with meningeal-type symptoms. Her CSF showed 550 whites. She received 5 days of combination therapy, and then she was eventually discharged. She came back, as many of you are aware from talking about this now, that almost all the patients that had meningitis developed infection at their site of injection. And she had back pain, lower extremity weakness. She had an enhancement at the inferior L3 level. And she was restarted on combination therapy, taken to the OR. In her OR, they found a small amount of epidural infection, a small amount of pus, but the majority of her findings were really intradural, phlegmon-like material attached to her nerve roots, or arachnoiditis. And she had abundant necrotic debris, and the GMS stains showed abundant fungal hyphae. She was treated with 2 drugs. You can see here, this is post-contrast images, the fat suppression images. These are images that our neuroradiologists use frequently to detect infection in this outbreak. The fat is suppressed, so the bone becomes black. And these are the axial images. You can see the clumping of the nerve roots. And this is not this patient, but this is this phlegmonous type material over the thecal sac. Her histopath, here you can see purulent inflammation and the GMS stains. So, you know, what happened to this patient? So she, a month into her hospitalization, she had stable arachnoiditis, stable intradural involvement, and then she was eventually discharged home on November 30th. She had about 5 weeks of combination therapy. She was better in terms of her back pain and her radiculopathy. On January 2nd, she underwent another MRI, and this showed decreased enhancement. Her L3, L4 pain was better. But about a month after this, so early February, and actually probably looking back even earlier than this, she had developed rib pain. And what she had, I'll show you in a second. So these are her images early on. You can see this dorsal epidural collection. And what I wanted to show you is that these images in January, I think these are images from January, really show that this, the arachnoiditis actually looks much better. So actually very encouraging. You can appreciate here that the intradural defects look actually better, just a whole lot of postoperative enhancement. So she actually has periostitis, and you can see here on the bone scan that she has uptake in her 7th and 8th ribs bilaterally, as well as her left 5th and 6th ribs. You actually appreciate it with her chest CT scan here. You can see the asymmetry. Her fluoride level, which takes a while to come back, her fluoride level was elevated at 7, normal is 1 to 4. And so we actually decreased her dose of voriconazole. So this is another case that I actually presented back in November that I'd also like to talk to you a little bit about. So this is a 74-year-old female who presented on October 3rd, and she had right-sided weakness and slurred speech. And so she was actually in the hospital at the time. There was all this media coverage for this outbreak, and her sister was watching the news, and she basically got a hold of the hospitalist at St. Joe's and said, hey, you know, my sister had an epidural injection. It was actually, you know, the story behind this is actually very, very sad. She's kind of the matriarch of her family, and she was a retired principal. And she actually went to London. She was an avid fan of literature and loved reading and loved plays. And to get to London, she had this back pain, and so she got an ESI, and it was unfortunately the only injection she received. So she actually really didn't have a whole lot of headaches, but based on this history, she ended up undergoing an LP. And you see here that she had 2,800 white cells. Pretty profound low glucose, elevated protein. Her PCR was positive. She was treated with combination therapy, and she really had a lot of difficulty with amphotericin and just was unable to take it. She eventually was discharged to our inpatient rehab, and she, like almost all our other patients with meningitis, also developed infection at the injection site. You can see here that she had this linear intradural stranding or arachnoiditis in the contrast images here. And she had a pontine CVA. You can appreciate it here. These are the diffusion weighted images and the flare signal images. And so she, there was some discussion of whether we might be able to do surgery in her for her epidural component. She didn't want to have surgery, and then she unfortunately coded, and then she actually recovered from this. And this is what I mean about the potassium really getting to be quite low. She eventually was treated at our inpatient rehab unit for about 3 months, and she actually was able to walk about 80 feet with assistance by the time she went to an ECF. Well, I saw her in late February, and she unfortunately over the last couple of days has actually represented back into the hospital. But she actually developed significant alopecia. Some of the women patients that we have are wearing wigs because of this, a really significant side effect. She also had rib pain and significant periostitis. Her fluoride level was elevated. And her MRI, which we did about a week ago to figure out exactly what I should do with her antifungal therapy, showed kind of stable arachnoiditis. Now, the way we managed her voriconazole is very typical to other patients. Now, despite low voriconazole troughs in her, I lowered the dose recently based on these symptoms. This here is just when we started off with her. So she's about 50 kgs, about 100 pounds or so, and she probably was started off about 400 milligrams twice a day. Really, there was this intense monitoring, getting levels very frequently. And this is a patient that did not have any previous surgery, really has significant arachnoiditis still based on MRI. And at this point in time, she was taking 550 milligrams twice a day of voriconazole. You can see that, by following these levels so carefully or so aggressively and trying to get to these levels of 2 to 5, many of these patients, and whether they became hypermetabolizers with time, whether they became autoinducers with time, but many of them had these decreased levels. Now, despite her levels being low, I couldn't have her living with periostitis because that pain actually was it was really disabling and crippling to her. So she is actually in the hospital as we speak. Now, the third case I present to you was a very telltale case for us. This was a 47-year-old gentleman who underwent a C6, C7 ESI on October 2nd. Unfortunately, the last day of injections at Facility B. And after he had the injections, he just didn't feel well. I saw him probably 3 times between October 2nd and before the time we picked up infection on him. So he had neck pain and spasms. He had 4 LPs, all negative. He had 3 previous MRIs from October 2nd through November 2nd. They were all unremarkable. Unfortunately, on November 13th, he did have enhancement picked up. And he did have evidence of a phlegmon and an epidural abscess. He was taken to the OR. And he had pathologic evidence of fungus here. He was treated for about 10 days and then discharged. And he actually is doing actually quite well. It's this group of patients, the spinal and paraspinal cases, and most of these patients we operated on. I think we've probably taken well over 100 patients to the operating room. So this group of patients that I think will do quite well. I show you his images here. This is the November 2nd MRI. This is the November 13th MRI. You can see here this epidural collection. You can actually see it a little bit better on the T2 images. You can see here the dura is being pushed out. Again, this is an epidural collection. And his path pictures here, inflammation next to bone, so osteomyelitis, and evidence of fungus. His GMS stains here. And I show you this because I think this picture helps appreciate the difficulties with obtaining MRIs post-surgery. You can see here that his epidural collection is gone, but there's all this post-operative enhancement, which is often difficult to interpret. Thankfully, he's clinically doing well. So there's lots of lessons that we've learned thus far with this outbreak, and we continue to learn. What I know now, what I know here in March is I know much more than I did about a month ago. I've learned new things about alopecia and periostitis. My management has actually changed in terms of how I monitor voriconazole in troughs. This is the largest healthcare-associated outbreak in the U.S., in the history of the U.S. thus far. CNS infection was clearly an evolving disease. I don't think any of us envisioned that patients were going to come in with infections at their injection site. A high percentage of infection at the injection site, and I think in the patients that we saw, I think actually if you really had meningitis, you did actually develop an infection at the injection site. I think early on, the incubation period for those that had meningitis plus spinal and paraspinal infection was very equal to the people that had just spinal and paraspinal infection. But we continue to see patients, albeit on the downward trend with spinal and paraspinal infection. I think the patients that I am personally most worried about with relation to this outbreak are those that have undergone a CVA, as I told you about case number 2, and the patients that have arachnoiditis. These patients clearly had a greater severity of illness. How long do we treat arachnoiditis? Well, I think it's going to be individualized, and I don't think it's one size fits all, but it is going to depend on how severe their symptoms were. Optimal duration of therapy, it's definitely not clear, and I think it's going to be individualized, and it's going to be based on their disease presentation. Timing of repeat LPs, there are people across the country, including folks from Virginia, that have undergone serial LPs. We have not done a whole lot of serial LPs. We are beginning to LP a lot of patients now. Our thoughts on this group of patients that had meningitis and spinal and paraspinal infections were that we were likely going to treat these patients for 6 months from when they underwent operative intervention, which for some patients will be coming up in May. Those patients will be beginning to LP now, but even LPs are difficult. In these patients, there's some patients that have extensive laminectomies. Say their ESI was L3, L4, well, they had an extensive laminectomy from L1 to L5. Well, where do you really safely do the LP, and do you really need to do an LP if they're clinically better? This here, again, is data that from Tom Chiller in the CDC. What I do want to show here is clearly patients that had stroke and patients that had arachniditis, they were sicker, and that's what we clinically saw. They had greater amount of CSF abnormalities, higher white cells, lower glucose, higher protein, and most of the morbidity with this outbreak, again, was early on where the disease really wasn't recognized. The other thing that I think is very interesting, and again, this is what we've seen clinically, it's these patients that have arachniditis, they're the patients that were most likely to receive combination therapy, and I don't think that we have duration on here, but also probably had the longest courses of therapy. I think nationwide, if you look at kind of the CDC breakdown, about 60% of the patients that had meningitis have had concomitant spinal and perispinal infection. Now, spinal and perispinal infections occur at the site of injection, and there's really no evidence of non-contiguous spread. Thus, when you embark under an MRI screening of hundreds of patients, it becomes very, very important to know exactly where their injection is. Surgical intervention, I think, from what we've seen at our institution and from what I've discussions with other folks, I think surgical intervention is a very important role. Clearly, you need to have a low threshold for MRI imaging, even in those that have a minimal change in symptoms or deemed asymptomatic. And the CDC has also followed suit with notices on December 20th and March 4th. Encouraging providers to get imaging. I think that there is a concern that there are a number of patients that have not undergone imaging yet. Optimal duration of therapy for these patients, for the most part, we're going to treat these patients for 6 months from their surgery. Repeat MRI imaging is often needed, but as noted, MRIs can lag behind clinical improvement. Joints, I likely need washout and debridement. Adverse effects of voriconazole, I think likely more prominent with higher dosing, and that's why we're seeing these effects much earlier than they've ever been reported like allocated to other hospitals. So it's actually very important to have a centralized unit for keeping track of these patients. And with this registry, we were able to also track the hundreds of MRIs that were coming. We developed a fungal outbreak clinic literally in a matter of a couple of days. It was kind of developed overnight, and it had some problems initially, but we've kind of evolved, and it's really played a vital role. It was initially set up as multidisciplinary, and as time is as we continue to go on here, it's really become mostly ID now. But we have a dedicated pharmacist, a dedicated case manager to help with all the studies that are occurring. We have a dedicated internist that is helping us manage MRIs. And regular calls and communication with the CDC, Michigan Department of Community Health, other states, other providers, really essential to ongoing management. A lot of teamwork over a lot of different areas. I won't spend too much time on that. I just show you this picture here. For 3.5 or 4 months, I think from October 4th or 5th up until mid-January or late January, we had daily huddles or incident command calls. It ranged anywhere from a half hour, sometimes longer. Sometimes these were twice a day. They were on weekends. But I think they were actually very helpful early on to have all of us on the same page. I know Sandro participated in some of these calls. And here, just the representation we had our chief nursing officer, our chief medical officer, we had media, we had our chief of staff, our director of pharmacy, our director of our ER, we had ID representation. So really a lot of the key areas. This is a picture of our fungal outbreak clinic. Now there's some unknowns and there's some remaining questions, and maybe these answers will become more clear with time. But so how did this pathogen enter into the CNS? I mean, why did some patients develop meningitis? That's still really a big question. What is kind of played out with some of the data from Tennessee and some of the data that you will see later on is that the translaminar approach that does seem to play out as a risk factor for meningitis. And why does the translaminar approach? Is it closer to the dura? I'm not sure that we totally know. Do they perf the dura? I mean, was there direct entry? I find that hard to believe for all the cases of meningitis. These procedures are done under fluoroscopy, so every image has a fluoroscopy recording of what was done. And the peripheral joint infections or injections actually they often have ultrasound imaging record for those types of injections. I think one of the more likely explanations is that there is continuous spread across the dura. The injection is given with a steroid. There is really no immune response. You're talking about an indolent pathogen, and with time, this is probably able to spread across the dura. We've definitely seen it in surgery. We've had our surgeons say, you know, the dura looks very abnormal. The dura had a coating. The dura was completely eroded. I think it's probably one of the explanations. Why did localized infections present later? Well, clearly there's less morbidity associated with this. They're less symptomatic because the patients that presented when this outbreak wasn't recognized, they presented because they had a lot of symptoms. I think, you know, there's probably a group and a range of how symptomatic you are. So again, I think coupled with the steroid injection and the fact that you have an indolent fungus may be responsible for why some of these infections are presented later. Incubation period for this, I still think it's not well defined. I think if you can see infections 6 to 7 months out, which we are seeing now, I think you can probably see infection a year out. You know, scary but probably true. Management of voriconazole toxicity. Well, maybe we shouldn't have been so fixed on trying to maintain these therapeutic troughs. I mean, the concern was that, you know, 50% of voriconazole gets into the CSF, and those that have meningitis, you really want to make sure and ensure it's getting there. But by using such high doses in patients, we've seen a lot of toxicity. I can tell you for a lot of these patients now, maybe not so much the arachnoiditis patients, but the patients that have had surgery, that have had spinal and perispinal infections, many of us are less inclined to follow those troughs as religiously as we did. Utility of other azoles. We have used itraconazole and posaconazole. We've probably used itra 10 to 15 times, and generally it's better tolerated in our experience. Mostly for peripheral joint and spinal and perispinal disease. What about for CNS infection? Well, I'm not sure anyone really knows. Use of beta-D-glucan, I think Chris will talk a little more about this. I think it's a tool that we've been using, a marker that we've been using a little bit more recently. Is there some role here? I think it's probably helpful if it's positive. I wanted to share with you a video. As much as I can kind of tell you what it's been like, I think maybe you can appreciate what it's like from an ID standpoint, what it's like maybe from an administrative role, what it's like from the bedside. I can't really tell you what it's like from a patient side unless you actually, unless you're managing these patients. So let me make sure this works here.
I was diagnosed with fungal meningitis in October of 2012. 5 months. I've been dealing with this for 5 months now. I can't believe it's been that long. You know, you have people telling you this is in you and this is what's happening to you. You're feeling some pain, but you're going, is this real? You know, is this really going to happen to me? And then you start hearing about the deaths. And it's real. It's very real. The first time I came, I spent 6 days that were just horrendous. Hallucinations and pain. Had my Thanksgiving here. I went home December 15th and came back on the 24th. I was really sick then. I mean, I drugged myself in here. For me, the medication has been tough. It's been a tough battle. It's hard on the kidneys. It's hard on the liver. It's hard on everything. The amphotericin, for me, is, I don't have problems with it now. I had problems with it at first. I went right into the rigors. And, you know, it's just you trembling and shaking so hard, your muscles are all locked up. and you would think you'd be sweating bullets, but you're freezing. And they're putting heated blankets on you to warm you up, and you start warming up, and then the hallucinations came on. Voriconazole, and that's some hard stuff to swallow. I sit down after I take it, and in 20 minutes it starts to hit me, and then for 3 hours I can't do anything. Can't remember things. You don't remember whether you turned the teapot on or off. You don't remember if you let the dog in and out. Nobody knows about this disease. There is no answer. We don't know if there's a cure.
And thank the marketing communications department who helped me with that video. For the sake of time, I'm just going to have Chris. Yep.
Yeah, Chris, as you're getting set, does anybody have any very specific questions for Dr. Malani? Otherwise, we'll have them both up at the end. Yeah.
Good question. For the lot for July, why was that not affected? You have the lot for June, May. It's a May, June, and August affected, but not the July lot.
I don't think there was a July lot that was produced. I don't know why, but there wasn't a July lot that was manufactured.
One last question.
Have you run into much hepatitis being a limiting factor of kind of dosing things properly?
Question for hepatitis.
Yeah. I mean, we have seen a fair amount of LFT abnormalities. I had a guy last week whose LFTs were in the 900s. Usually my threshold, it's probably gone up with time. I've tolerated up to probably about the 500s where I've switched to other azoles. Again, it depends on what type of infection they've had. And that necessarily hasn't been a cross effect or cross-class effect. We've had people with voriconazole that developed LFTs in the 500s that were able to transition over to itraconazole that did okay. So probably not too much.
Okay, we'll have both the physicians available after Dr. Ledtke's presentation. So.
Hours worth of slides, so sorry for that, but I want to give a little background on myself. I finished fellowship in June, and if any of you remember your first year out of fellowship, you basically don't know what you're doing at all, and you're kind of like a deer in the headlights for the whole year. I moved to a different city, a different hospital system. I was on my own for the first time, so there was a great deal of self-doubt, a great deal of uncertainty, and this was uncertainty on top of uncertainty. So this was a very humbling time for me, and I thank you for letting me come here and talk about it. So Dan wanted me to talk about peripheral joints, which I have a couple slides on, but really what I want to tell you is what we experienced in Traverse City, which was, although the same exposure for patients, a vastly different experience than what they had in Ann Arbor. So this is the map of states involved, and of course Michigan, as we all know, had the most amount of cases, and most of those were downstate, although Traverse City had about 20% of all Michigan cases. And actually more than any other state, Traverse City had more than any other state except for Indiana, Tennessee, Michigan, and Virginia. So this is a very serene picture from our pain clinic in Traverse City, Neuromuscular and Rehab Associates, which is not associated with the hospital, Munson Medical Center. These were the three lots that were implicated, that were contaminated from New England Compounding Center, and our center utilized two of these lots, in particular the lot that began with 05 and the lot that begins with 06, so lot 05 and lot 06. And we got 1,500 vials between those two lots. So these products were distributed by the New England Compounding Center between May 21st and late September. Our center used, this is hard to see, and sorry about that. This is from the FDA customer list of who actually received New England Compounding Center products. And you can see that our center received 1,500 total vials, the first of which, the first of which was June, late June, and then one in July. And this one in particular was lot 06, received on August 13th. And so we have this pain center in Traverse City. They also have 2 satellite facilities in Gaylord and Charlevoix that utilize the same products. So I want to touch for a second on this study from New England Journal. It's a cohort study from Tennessee with their first group of patients looking at risk factors for developing infection. Why did some patients develop it and some patients not? A couple in particular, translaminar injection had a relative risk of 2.5. This lot, the 06 lot that I've mentioned, had a relative risk of 6.2. So why does, this seems to be a potent lot, this lot 06, and there's a couple reasons why I say that. First of all, we weren't utilizing this till August 13th. That's when we had it delivered. We injected 531 patients from August 13th to the afternoon of September 26th when they came and took all those vials away. We used 380 vials of this lot. Among all of our reported cases, there were only 2 that were injected before August 13th, and all of our confirmed cases were injected after August 13th. And beyond that, Michigan pain specialists in Brighton, which is the biggest source of infection nationwide, only use this lot 06. So this seems to be the smoking gun. So the FDA came and took the remaining vials for analysis, and they took 83 vials from the lot 05 and 120 vials from 06, which means that we used just under 1,300 vials of these products in this time frame. So all of our injections were done fluoroscopically with this product. They only use preservative-free methylprednisolone in fluoroscopic guided procedures. If you look at whether the patients got multiple injections, the median number of injections per visit is 2. The majority of patients got multiple injections, 60%. And patients got anywhere from 1 to 6 injections per sitting. And the median dose was 80 milligrams of methylprednisolone, and it ranged from 10 to 160 per injection site. So in contrast to their experience in Michigan pain specialists in Brighton, our injections were mostly done transforaminally versus the alternative translaminar. So Anu had a similar graphic. These are the 2, basically the 2 ways to inject steroids into the epidural space. Apparently the transforaminal, they think it's better at getting the product on the nerve root itself, and for nerve pain, that's supposed to be more potent. Now, the biggest concern is dural puncture. I could not find any data that said that one has a higher risk of the other for causing this. When you're doing a procedure through a neuroforaminal method, your biggest concern is puncturing the dural sheath of the nerve root, which goes through that foramen. The translaminar is simply a risk of puncturing the dura itself. So if you look at the literature, for an epidural steroid injection, the overall incidence of dural puncture is 2 to 5%. I think that's a little high. If you talk to our physiatrists in Traverse City, there's this post-dural puncture syndrome where the patients get headache, vertigo, nausea. It's supposed to be like the worst hangover you ever had. And that's fairly recognizable. These physiatrists at our facility said they almost never hear anybody report this. So I think the incidence of dural puncture is very low. So unfortunately, our pain specialists, when they stock their methylprednisolone, they use a large drawer that they just take basically the top product out. They do not document which lot each patient gets. So basically, anybody who received an injection during the time frame of when New England Compounding Pharmacy was distributing these could have been potentially exposed. And as far as the dates, when we were initially talking about who we would contact until you've been exposed, we ended up going back to the beginning of May just to be sure, because we weren't completely sure which dates we got these products, and there was a little bit of uncertainty. So we went all the way back to when they started distributing, and this included 1,031 patients who were potentially exposed. So if you look at the facilities in Michigan and potential patient exposures, Traverse City had quite a high number. And this is when things really started getting crazy. So you can imagine if you call 1,000 people in northern Michigan and tell them they're all chronic pain patients, and you tell them you could get this meningitis that we don't know anything about, and look for these nonspecific symptoms, and then call your primary doctor, who also has no idea what to do. So it was a mess. So the ER took the brunt of the first wave, I would say. They were doing lumbar puncture after lumbar puncture after lumbar puncture. We were able to set up a hotline, although not until after the weekend I was on call, where we fielded questions from not just patients, but primary care doctors and hospitalists. And they actually were more commonly calling them patients, and what do we do with these? And of course, there was tons of uncertainty. We set up a fungal meningitis task force. We had daily meetings, which was multidisciplinary, included a lot of administration, radiology, ER, ID, infection prevention, and the ID consult service, of course, was very, very busy. It was a very dynamic situation, and we were learning new things every day, and there was a lot of uncertainty. So as Anu mentioned, initially in the outbreak, meningitis and stroke were the main concern. And so we were very worried about this, that we were going to find these. And so we were doing a lot of lumbar punctures. And even after all of those lumbar punctures, we only found 6 patients that met CDC criteria for reporting. And that the definition for that would be somebody who is symptomatic, who had pleocytosis of 5 or more. Of those 6 patients, 3 of them had white CSF pleocytosis less than 20. None of them died, none of them developed a stroke, and none of those cases were confirmed positive, and positive being either culture, histopathology, or molecular assay. If you look at the imaging for these patients, only 1 of them developed epidural enhancement, and none of them had a defined abscess. And our main patient load was patients who presented later with local injection sites. And meningitis was very, very minimal. And the reasons for that, we're not entirely sure. So from a national standpoint, patients who presented earlier in the outbreak, this is a cohort of patients who presented by October 10th, reported by MMWR. 91% of them were meningitis cases. And if you look at a cohort of patients in mid to late November, less than a third of them were meningitis. And now you're getting to see the vertebral osteomyelitis and epidural abscesses. So the CDC put out this data, which actually was really, really helpful in calming patients and care providers, that the risk of meningitis goes down quite significantly the further out you get, and after 6 weeks, your risk of developing meningitis is less than 1%, which I think having some data like this actually was quite helpful during this outbreak. So this is a graphic from a JAMA article earlier this month. It's a really nice graphic. I don't have time to go into much of it, but this is the 30-day case fatality rate. This is only meningitis cases. And you can see that was extremely high, 50% in late September, early October, and then dropped dramatically once basically the alarms were sounded and people were watching out for this. And it dropped to extremely low levels and remains so. So as far as the patients that we saw and some of the data from there, we evaluated over 270 patients. Only 51 of those were reported to the CDC, and only 16 of those were confirmed positive. So of all the patients that we reported to the CDC, paraspinal was the biggest proportion. You can see our meningitis cases, our soft tissues were mainly bursal, and then a few septic arthritis, all of which were hip. Among our paraspinal infections, they're fairly evenly broken down between epidural abscess and sacroiliitis. It also includes quite a bit of facet, septic arthritis, which is probably the most challenging patients that we've seen, and vertebral osteomyelitis. These are just the confirmed cases. We had a lot of bursitis that was confirmed, and a lot of paraspinal involvement, which was evenly distributed basically between sacroiliitis and epidural abscess. This is a Venn diagram of how we made the diagnosis in our confirmed cases. And you can see that there were 8 patients where the PCR was the only, so CDC testing would have included either PCR or immunohistochemical staining. So the CDC testing identified 8 patients that were negative on culture and histopathology. But we had 2 patients who were positive on histopathology whose CDC test was negative. So you can see it's a difficult fungus to find. It's a difficult diagnosis to make. Peripheral joints. A lot of peripheral joint infections in Michigan. In fact, there's 30 cases reported. This is from mid-February. This is from an abstract that was submitted to the EIS conference in mid-February. 30 peripheral joints have been reported nationally at this time, and 22 of those were from Michigan. It seems to take around 60 days or so from the time of injection to the first abnormal MRI. Quite a few of these were asymptomatic, 77% of them. And the median joint aspirate was 960 white cells, and only 5 of these were confirmed positive. This is statewide. This is not just Traverse City. This was data collected by one of our very good infection prevention nurses, and this is a lot of data, and I don't want to go through all this. Basically, what I'm showing here is the MRIs that we got off the bat. Many of them were done in asymptomatic patients who either just came into the ER for clarification or were sent in by either their primary doctor or their physiatrist. And you can see that symptomatic and asymptomatic patients, there's really not a lot of difference, not a significant difference between who's more likely to have an abnormal MRI or not. Interestingly, this is the breakdown in when the MRIs were abnormal, what did they show? And you can see that actually 54% of the symptomatic patients were normal, and 49% of the asymptomatic patients were normal. So you were actually more likely to have a normal MRI if you were symptomatic off the bat. So basically, it doesn't correlate with symptoms. This just shows basically how our MRIs progressed over time. And this is a look at patients with serial MRIs, which we did in the majority of patients. And it's kind of a mishmash of, a lot of patients had no change despite months of antifungal therapy. And then patients, quite a few either improved or progressed. And so we did do a lot of serial MRIs, and those are what we found. So the beta-D-glucan testing we started doing fairly early in this outbreak, not knowing whether it would pan out to be helpful or not, but because of how difficult this disease is to diagnose and the great degree of uncertainty, we thought maybe just adding one more element would be helpful. Among our patients reported to the CDC, 20 of those cases had positive beta-D-glucan testing. It was only checked in 37, so 65% of our reported cases were positive. It was negative in 11 patients. In the median level was 91. It's a quantitative test. If you look at our confirmed cases, however, 11, so it was not checked in 4. So 12 patients had this done. I only included it if it was done at disease onset, at the first time they presented. So 92% were positive, and it was negative in only 1, and that 1 was 58. So negative is technically less than 60, but most patients, if they don't have a fungal infection, will be less than 30. Okay, so even our negative case was just below negative. The median level was 270 among confirmed cases. Inflammatory markers we did a lot of too, turned out to be not very helpful. Not very different between confirmed and reported cases, and even in confirmed cases, only positive in 56 and 63% for CRP and SED rate. So procedures were big. I think we got a little happy with interventional radiology. We went a little crazy, mainly because some of these locations, it was difficult to convince a surgeon to go after, particularly the facets. So of our reported cases, 30 of them underwent imaging-guided aspiration or biopsy. Okay, now this represents probably the minority of people who got this procedure done. We did a lot of these. A lot of people sent down for like a core biopsy of paraspinal tissue. When I look at our records, I can only find 2 patients that had anything positive on those. And I would say we had probably close to 100 or more sent down. So that was not a very useful. It was probably more of a delay tactic, but ultimately 30 of 51 did require surgery. All of our confirmed cases went to surgery. And then 14 patients went to surgery directly without getting any interventional radiology. So our mainstay, because we did not have much CNS involvement, was voriconazole. Although it does have good CNS penetration, we treated most of our patients with voriconazole alone. We did weekly blood work on these people, liver function testing. We got a voriconazole trough every week, which is a send out. We checked a blood count. Of course, the duration is a little iffy. Patients who I start on therapy, for the most part, I would expect would get a minimum of 3 months. People with severe CNS involvement and osteoarticular involvement would probably get 6 months. And if osteomyelitis is documented, they probably should get closer to a year. And these people who complete therapy, which I've only done on 1 or 2 patients, have to be watched very closely because there's so much uncertainty on how long you're supposed to give this. These are patient-reported side effects of voriconazole, and these are all real. One in particular, former President Faces, is never been, this patient thought that every person they saw was a former president. And so there was a lot of Nixon and Carter in there, and so it was very disturbing. And so patients who are, first of all, who have an infection that they really don't know much about and are on a medication that can produce all kinds of side effects that they can really, any problem that they have, they can either chalk up to the infection or the voriconazole. And I mean anything. Hot dog fingers. Anyway, so let me go through a couple cases. Okay, I gotta go fast. We need time for questions. Okay. So I got 3 in particular. These are all patients I saw myself. This guy is from Leland. He's a retired NFL football player. He played for John Madden for the Raiders. He was a linebacker. So he had a lot of chronic pain because of, putting the hurt on running backs in the 60s. He underwent injections actually for the first time in Brighton on September 20th. He had been using just pain meds before that, but his wife convinced him that he needed injections. So he went down to Brighton to get the injections, and but he lived up in Leland, so he lived up north. He came in October with a flu-like illness. He underwent a lumbar puncture. It was non-inflammatory. He was admitted at that time, was actually not seen by infectious disease, and it was on the weekend. So they imaged his cervical and lumbar spine, and his pelvis didn't get imaged because they didn't have access to where he actually got injected. So unfortunately that was missed. And then he had a repeat MRI done in late November because of progressive symptoms of actually hip pain. And this is his MRI. You can see that this is a sacroiliac joint. The right side is extremely inflamed and enhancing, and this is the axial view. So this was one where this was early December. So by this point, we didn't even bother with IR. We just called our surgeon, who orthopedics was very helpful with this. Took him to surgery, and the orthopedic doctor called me and said, "It looks like fungus." So when they were in there, I guess it's more mucousy, granular, looks different, not purulent, has a totally different look from a gross anatomic standpoint. He grew extrahilum on day 2. His beta-D-glucan test was 438 at presentation. This is his extrahilum. And you can see the little hot dog shaped conidia. I've been told that rostratum means beak-like. So they're supposed to have like a beak-like or pointy projection. Anyway, so this guy went on voriconazole. He's been on it since early December. This is his MRI about 2 weeks ago. And this is his MRI in November. So he's had quite a bit of improvement. Actually, now he's exercising a couple days a week, and he's doing really well. Case number 2 is a little bit tougher. This lady's 83, has a bunch of medical problems. She got injected in both SI joints in September, and then when they did it, in late August, and then in September, when they did her second SI joint, they injected her left trochanteric bursa as well. So she's had worsening pain since shortly after the injection. This is her MRI. This is her bursa. And this was in late November. And I was on the hospital service. She's an elderly woman. She's got pain everywhere. And she couldn't tolerate an MRI, so we only had one MRI. We couldn't do serial MRIs. We ended up doing an IR-guided biopsy, which was negative, and she had negative inflammatory markers, so we decided to wait and watch. I saw her in clinic. She was getting worse. Her inflammatory markers had increased, and I decided at that time to check a beta-D-glucan, which was positive, 320. And I called the surgeon, and since we failed on IR before and she couldn't tolerate MRI, we just sent her in for surgery. So this is her like a low power view of her bursa, which I'm told shows chronic inflammation, but I don't speak pathology. So this is not a giant fungus. This is a hair or something, other artifact, and or a marker, I don't know. And this is a silver stain of her bursa with extrahilum. Now these look a little funny. The patient had been on voriconazole for about 2 weeks prior to surgery, so I think there was some effect from the medication. All right, I'm getting close. So, and then this is her, I know there's only 3 data points, but this is her beta-D-glucan titer in regards to her initial presentation and her surgical debridement and when she started antifungal therapy. The last case, and then I'll finish quickly, this, I think, I need to go through because it represents the basis of why this is so challenging. So this lady is 40 years old. She's very obese. She's a former nursing assistant. She has lots of pain because of lifting obese patients. So she got bilateral steroid injections to L2 through S1 basically on September 26th in the morning. Now keep in mind they came at about lunchtime to pick them up and take them and pull them off the shelf. So she missed it by like a couple hours, but she did get injected. So she's had worsening pain since the procedure. She had fevers, subjective fevers, headache. CSF was negative. I think we did a lumbar puncture 3 different times. She had mildly elevated inflammatory markers, and her MRI, this is her facet. So it's enhanced on the right side. We attempted to get a CT-guided biopsy of this tissue, showed some chronic inflammation, and fungal stains were negative. They didn't have enough tissue to send to the CDC. Every cultures were negative. Her beta-D-glucan was negative. We put her on voriconazole and discharged her. And then, no surprise, she didn't tolerate voriconazole. And I ended up taking her off because it wasn't a confirmed case, and I wasn't totally convinced. Her follow-up MRI off voriconazole 3 weeks later was negative. And her husband's calling me and telling me that she's getting worse. And I keep seeing her every time, and her MRI continues to improve off of therapy, and her lab work looks totally normal. And as long as I talk to her and calm her down, she does fine, but she's a very challenging case. So is there any end in sight? I think we're starting to get there, although I think we're not going to be done with this for years. The incubation for especially the bone and joint type of infections is not well defined and could be quite late. The only comparison we have really is this small outbreak in 2002 with another fungus called Exophyla, which only affected 5 people, but their sacroiliitis case had an incubation period of up to 152. And of course now the whole legal implications are coming into play, and we're starting to deal with those. So I have a lot of people to thank as well. Sorry if I didn't leave much time for questions, but that's it for me.
We are gonna take some questions. So if anybody has any questions for Dr. Ledtke, and Anu, if you could come on up as well. Yes, sir.
Speaking the tab for all this.
Who's picking up the tab?
Yeah, if you can use the microphone.
Yeah, no problem. So,
You're only talking to
Oh, we're only talking to her.
okay.
Yeah, these
So when this first started in early October, we thought, why don't we try to get some money from NECC or from, and that was of course futile. So for the most part, insurances are covering the voriconazole, they're covering the hospital stay, they're covering the MRI, but we spent a lot of time on the phone getting prior authorizations, filling out forms, and so I haven't had too much trouble getting stuff paid for, but it usually requires quite a bit of work and time.
Any comments on that? Who's paying for all this?
So so for MRIs, I can tell you that was a challenge. I mean, you know, when you're talking about hundreds and hundreds of MRIs, we had to jump some hoops, through some hoops for the payers, for certain information that they wanted. But that got itself worked out. I can tell you that our, Trinity, St. Joe's is a part of Trinity. I was at a recent retreat a couple days ago where our CEO was talking about the outbreak, and he said that so 50% of the patients affected in our health system are Medicare patients. So I know Trinity was up on Capitol Hill because this is a big issue, because this affects Medicare readmission rates, affects reimbursement, it's downstream, there's a whole host of issues, and our readmission rate for some of these patients early on was about 30%. So I'm told that CMS is aware of these issues and is working on it.
Okay, other questions? I guess I had one question. I saw in the newspaper not long ago there was another compounding center that was found to have fungus and was shut down. Is this really just the tip of the iceberg? I mean, how many compounding centers are there out there, and what are we really dealing with?
Well, so that's a good question. I think this is one of these situations where there's clearly something that's been done wrong, and it takes a tragedy to change people's practices. And these compounding centers are not FDA regulated, and they're regulated by state pharmacy boards, and so there's going to be a lot of legislation. I think this is going to change things as far as these compounding centers, these sterile products, and who is watching over these centers. And there's quite a bit of new legislation with that. It's a dynamic process. So, what do you think?
I would agree.
Yeah.
I mean, yeah, or the same thing. A lot of concerns
What's
there.
the implication for the pain people who actually got involved?
That's another good question. So, go ahead.
And are they going to take the moral high ground from now on and get proper medications rather than from compounding centers? Because it's all about American greed. It's
Absolutely. And the question came up quite a few times to me is, why are these patients getting multiple injections at multiple sites? How many of these are indicated? So I don't know how many of these procedures were actually indicated to begin with. Our pain specialists have been very, very good. Every patient that gets admitted, they come in and see personally, they write a note, and they're on top of it. Now, whether they can be implicated or not, I don't know. There was some mention that the product itself had visible particulate in it. So I don't know if there's a procedure for visually inspecting product before you inject it. I don't know. But that, if anything, that would be one of the implications, but I don't know if that'll stick.
Just to comment a little bit about compounding centers. So, there is a role for compounding centers. And, you look at just in the state of Michigan, there's a lot of health systems that receive products from NEC. Maybe they weren't steroid injections, but there are a lot of products that come from NEC. And they do have a role because hospitals aren't, there's certain issues with how much and what they can compound for. You take ocular products, say someone has endophthalmitis, well, the hospital actually can't compound it. Those are compounded antibiotics. You need to get them from someplace. At least at our institution, they can't compound. So there is a role for compounding. Exactly how they're regulated is probably another issue. But the pain docs got these injections, and there's probably issues there. But there's also issues of supply and demand. And is there enough supply if you take places like this out of the picture? I don't know the answers to those, but
They do a lot of other things. So, any other questions? If not, I think the society really owes a debt of appreciation to not only these two physicians, but all the physicians. They really stepped up and really took care of these sick patients, and just really appreciate everything you guys have done. And as a token of the appreciation of the society, there you go. Thank you very much.
Thank you.